Welcome to today's live surgery. I'm a moderator, Professor Suambyun. Today's operator is Seungmin Chung for live surgery. Dr. Seungmin Chung has performed successful live surgeries. He has prepared two unique and special cases today that is centered around minimalism and narrow reach for aesthetic appearance. Okay, let's begin our first live surgery. But before we get into it, I will give you a brief description of the patient prior to the surgery. We will receive your questions regarding the live surgery. Please do not hesitate to ask questions. The first case is labial bone augmentation and ridge expanding. Chief complaint is I need to get dental examination at upper anterior area. This is a preoperative panoramic radiograph. We can find reduced bone density at anterior maxillary area. This is the preoperative clinical photo. We can see the 8-unit bridge at maxillary anterior area. The bridge was removed for implant surgery. The ridge width of 11 and 21, both incisor area, is narrower than that of adjacent tooth area, the canine and premolar area. Let's check the preoperative CT images. There is a concave and narrow ridge at area right upper incisor. Since the labial bone shows severe bone resorption, we are preparing bone grafting, bone augmentation in this area. There is a concave and narrow ridge at left upper incisor area. Thus, we are planning minimal invasive implant surgery by using bright tissue level implant. We are planning saving right upper canine and first premolar. And implant placement at both the incisor area with bone grafting. And in addition, post and core restoration at left canine area. This is bright root canal implant. We will use this implant for post and core restoration at left upper canine. The root canal implant is made with titanium alloy, which provides excellent biocompatibility and balanced strength. It has elastic response to traumatic stress. Taper design prevents root damage. Let's talk about similar case by using bright root canal implant. This is pre-treatment panoramic radiograph. Right upper incisor was fractured. The right photo is the fractured crown. The tooth could be restored by using bright root canal implant. Endodontic treatment and canal preparation were done. The canal was pre-treated and filled with resin. Finally, the root canal implant was inserted and the upper crown was fabricated. This is the post-treatment panoramic radiograph. The bright root canal implant looks very simple and easy. This is today's surgery plan. Dr. Chung, he will place two bright tissue level implants at both incisor area with ridge expansion. He will perform simultaneous guided bone regeneration at anterior labial area for enhancing aesthetic appearance. We are planning to make a provisional restoration after a week. Let me show you a similar case of Dr. Chung. Dr. Chung has used bright tissue level implant at anterior narrow ridge area. He usually expanded narrow ridge by using ridge expander drill of Dentium ridge expansion kit, RE kit, and 2.5 and 3.0 bright tissue level implants were placed. We can overcome severely atrophic narrow ridge by using tissue level bright implant. Additionally, this case, osteoin-3 collagen and collagen membrane were grafted at the defect site. This is post-operative radiograph. He used membrane pin to fix the flap. The membrane pin, there are two types of membrane pin, the long and short. The long membrane pin can be used for fixation the flap. Final prosthesis was delivered. And this is another case. There was missing tooth at left incisor area. Flap was elevated and ridge spreader drill of Dentium kit was used. Vertical incision should be done to identify the buccal side bone. Bone level implant was placed and the exposed fixture was covered with osteoin-3 collagen and Dentium collagen membrane. This is a small collagen membrane. The size is 6 by 5 millimeter. To prevent exposure of grafted bone, free gingiva was harvested and grafted. The primary closure was achieved. The fixture and grafted bone were not exposed. And after few months, second surgery was done. Second surgery was performed only by using step incision. This is final prosthesis. And this is end of the similar case, and now we are moving on to the live surgery. This was just a brief description prior to the surgery, and I guess the live surgery is ready to begin, and let's move on to the operation room. Okay. I guess the operation room is ready to begin. He's doing the circular incision at the left upper canine area. This is cluster incision. When you make a cluster incision at the anterior maxillary area, we should be cautious of the incisive papilla. If we cut the incisive papilla during the surgery, the patient feels discomfort due to inflammation and swelling. That is very important to avoid the incisive papilla at the anterior maxillary area. Is cutting the periosteum definitely. Dr. Chung did 2 circular incisions at both adjacent tooths. I guess he is trying to remove the periodontal pocket. When we make an incision around the adjacent teeth, we can make a 2 incision around the tooth for removing the pocket. The periodontal pocket and granulation tissue may hinder the osseointegration of fixture. Especially, there always have to be granulation tissue around the incompletely healed extraction socket. We should remove the granulation tissue with bar or periodontal thread. The incision should be made on the parietal side of the drilling point, the expected drilling point. I recommend placing the crest incision slightly towards the lingual or parietal side of the expected drilling point. If we place the crest incision palatally or lingually, it is not difficult to cover the gravity bone with buccal or labial flap and connecting the healing abutment. He is grinding the bone around the left upper canine area. Since the left upper canine will be restored with a new crown due to the region he would perform the crown lengthening. And he inserted a pin at the mid area. I think he inserted the pin into a nasopalatal foramen to locate and and place the implant exactly. The pin could elevate the plaque side flap slightly during the surgery. When the bone is hard with severely observed narrow ridge, like this situation, a high-speed surgical burr could be used in the cortical bone to make implantation site whole. We can use the surgical burr with high speed as an initial drill instead of Lindenmar or guide drill. Now he is expanding the alveolar ridge to place the larger, wider implant. This is a ridge expander drill of Dentium kit. We can use the ridge expander drill with 50 RPM and 70 Newton. When the ridge width is from 2 to 4 millimeter, we can expand the width only by using the ridge expander drill of our kit. Now Dr. Chung is placing the 3.5 tissue level, 3.5 by 9 millimeter tissue level bright implant at both incisor area. We can place 2.5 or 3.0 tissue variety implant at anterior side. 2.5 bright tissue implant very useful to overcome severe narrow ridge. The fixtures were installed with 50 RPM and 70 Newton. Now he is elevating the labial periosteum. It is very important to identify the buccal or labial side, because even when we check the bone condition prior to the surgery, even when we check the bone condition by preoperative CBCT, there is a risk that the bone concavity or severe bone defect is at the labial or buccal side of the alveolar ridge. So I prefer to elevate the labial or buccal flap at the anterior area. He grafted osteum-3 collagen at the labial side. He used 6 by 10 osteum-3 collagen and 6 by 5 osteum-3 collagen. We should also check the palatal side of the implant to identify the bone defect at unexpected area. The bone grafting is done. Dr. Chung performed anterior augmentation with osteum-3 collagen. Osteum collagen is very useful to increase volume, especially at the anterior side, buccal and labial side of the maxilla. It can enhance the aesthetic appearance of the patient. There are various methods to apply collagen membrane or collagraft on the grafted bone. Simply, we can put it on the grafted bone without fixation. However, fixation of it is recommended with either GBR pin or sutures. Cutting and pressing a membrane, collagrafting over the healing abutment and fixture is another option. The collagen membrane and collagraft have sufficient mechanical strength to endure repeated manipulation. He is placing the membrane pin to fix the labial flap. He used 4.5 length membrane pin. The 4.5 membrane pin is very useful to fix the flap instead of the sutures. We can remove the membrane pin after 2 weeks with multi-cut. Very simple technique. Many study about the bone resorption of long-term follow-up stated that the absorption rate of simultaneous particulate graft is approximately 50%. Because of that, I performed the bone graft twice as large as the defect size, considering that it will be observed later. When we perform the fixed type implant prosthesis in the maxilla, labial augmentation can improve the patient facial appearance. Labial buccal augmentation can also improve patient satisfaction. There are two options to cover the insufficient soft tissue site. You can increase the amount of soft tissue by using a releasing incision or collagraft of dentium. If you decide to use releasing incision technique, that should not be done on the parietal side of the maxilla. The buccal region or the labial region has more soft tissue, making it easy to cover an implant and make it a better candidate for releasing in the soft tissue. Using a releasing incision on the parietal side is very difficult because of the amount of soft tissue available and the location of the greater palatal artery. Now we are receiving your questions regarding this live surgery. Please do not hesitate to ask questions. Okay, that's the end of the surgery, and to be honest, I'm a real-time relay, but the implant surgery was taken 10 days ago. We are showing the post-operative panoramic radiograph, and no problem are noted in panoramic radiograph. Okay, let's summarize the first live surgery case. He placed 2 implants with anterior augmentation and ridge expansion on anterior area. He used osteointic collagen and bright tissue rubber implant. The implants are well positioned as we planned. This is post-operative CVCT images. The fixtures are well placed and the grafted osteointic collagen are also well positioned. This is the clinical photo at 5 days after surgery. The membrane pin is well fixed. You can see the proper wound healing condition, and we can find the bright root canal implant is well positioned. At the time, we took intraoral scanning for fabrication of provisional prosthesis. Virtual setup was also conducted. This is provisional restoration. We know that connection of implant and natural teeth is unfavorable treatment option. However, this is provisional restoration only for 1 or 2 months. So we decided to connect the incisor with canine and premolar. Recently, provisional restoration was delivered. The surrounding soft tissue is well healed. Okay. Let's check the Q&A. Okay. Okay, first question. Even when the bone quality is poor, can we make immediate prosthesis? Actually, I don't recommend to make immediate prosthesis when the bone quality is poor. When the bone quality is poor, we can achieve the sufficient initial stability of the fixture. In this situation, if we make the immediate prosthesis, the failure rate could be higher than submerged situation. So if the bone quality is poor, and I don't recommend to perform the immediate loading procedure. Okay. Thank you for your valuable question, and let's have a break for some minutes to prepare next live surgery. Thank you for time and attention. Welcome to today's live surgery. Let's move on to the second live surgery case. The second case is focused on narrow ridge implantation with minimalism. This is preoperative panoramic radiograph. This patient got implanted placement at area number 13, 14, 15, 16, 23, 24, 25, 26 at 4 years ago. However, since there was severe bone resorption, the number 13, 14, 23, 24 implants were removed 7 months ago. And number 15 and 25 implants were extracted 5 months ago. Healing abutments were connected to the both first molar implant, and now the patient is wearing full denture at upper area. We are planning to place 2 implants at both upper incisor area. We will use tissue bright implant. Dr. Chung will choose bright tissue implant, and if necessary, he will use bone grafting, bone regeneration products of Dentium. This is preoperative CBCT images of both incisor area. Right incisor area has enough labial bone. This is left incisor area. This area also has sufficient bone. Bone grafting would be unnecessary at both incisor area. This live surgery could be performed with minimalism. Let me show you a similar case. 2 implants were planned at both lateral incisor area. Minimal incision was performed and path beam was applied to check the path of drilling. Minimal incision, the step incision, and slight little vertical incision. 2.5 bright drill was used finally to place 2.5 bright tissue level implant. 2.5 bright tissue level implants were placed, and second comfort caps were connected. This is post-operative panoramic radiograph. Final prostheses were well fabricated and delivered. Okay, let's move on to the operating room. I guess the second live surgery is ready to begin. The second live surgery case is very similar to the first live surgery case, but this case is much easier and simple than previous one. He's making the crest incision at the operation site. As I mentioned before, we should avoid the incision papilla to prevent post-operative swelling and discomfort. He's cutting the periosteum definitely by using periodontal thread and periosteal elevator. He is elevating the both side periosteum to identify the bone condition of buccal, labial, and palatal side. When we elevate the palatal side flap, we should be cautious of the inserts nasopalatal nerve. We can see the particulated bone at the surgical site. I guess there was bone grafting at the anterior maxillary area. It looks that there are enough bone amount at the labial side. He's cutting the exostosis of the alveolar ridge with bone longer. Debridement and removing the granulation tissue are very essential procedure prior to the implant placement. Since the granulation tissue and incompletely healed grafted bone can hinder the osseointegration of implant to the host bone. He's grinding the unfavorable shape of the alveolar ridge with a low-speed round burr. We can remove the granulation tissue by this procedure. Low-speed round burr can detach the granulation tissue from the host bone. During this procedure, saline irrigation is very important. He would insert a pin into the nasopalatal foramen and used it as a guide to locate the nasopalatal nerve and place the implant. As I mentioned before, the pin could elevate the palatal side flap slightly during surgery. When the bone is hard with the severely narrow ridge, a high-speed surgical burr this burr could be used in the cortical bone to make an implantation site whole. We can use the surgical burr, high-speed surgical burr, instead of the Lindemann drill or guide drill at the initial stage. Now he is drilling with 3.0 implant drill of bright surgical kit. He finished the implant drill. He drilled the 3.5 bright drill with 1000 RPM and 35 Newton. He just performed two-stage drilling. The first one is the high-speed round burr, high-speed surgical burr, and the second drilling was 3.0 bright implant drill. And finally, he is placing the 3.5 tissue level bright implant. 3.5 by 9 millimeter. At the left upper incisor area, he is also placing the 3.5 by 9 bright tissue level implant with 50 RPM and 70 Newton. Now he finishes the implant placement. He removed the pin from the nasopalatal foramen. He is checking the possibility of primary closure. I guess there is enough soft tissue around the fixtures. He is modifying the surrounding gingiva to increase attached gingiva at the major side of fixtures. He is cutting the palatal side gingiva and rotate the gingiva toward the major side at the both implants. This is modification of pouch flap. The suture is the silk is ethylene 40. This suture looks like horizontal metal suture. Yes, horizontal metal suture. Healing abutment or the scan comfort cap will be connected to the fixtures if the fixtures are stable. Connecting healing abutment or scan comfort cap can reduce the effort to do the soft tissue coverage. If possible, I always try not to cut the attached gingiva. Just cut and rotate. I don't remove the attached gingiva. The soft tissue defect on the major or distal side of the implant will fill in via a secondary healing procedure. He is doing horizontal metal suture and interrupted suture. There are many kinds of sutures, with the interrupted suture being the most popular. However, if you want to be thorough, I recommend using the horizontal metal suture and reinforcing it with occasional interrupted sutures, like this situation, like this case. Dr. Chung is changing the amount screw to the scan comfort cap. We can take intraoral scanning by using scan comfort cap of Bright implant system. One thing you have to be careful of is when you are storing the frenum. You can prevent the adhesions of the buccal and labial frenum by storing them with key sutures that don't allow a lot of movement. This is the area where you have to use the most reliable suture, such as the horizontal metal suture. Okay, we will receive your question regarding the second life surgery, and please do not hesitate to ask a question. He is also changing the mount screw to the scan comfort cap at left upper incisor. I guess the second life surgery almost end. Okay. That is the end of the live surgery. We will show the post-operative panoramic radiograph shortly. We will now take a look at the post-operative radiograph. No problems are noted in this radiograph. Okay, let's summarize the case with this radiograph. Dr. Chung placed 2 implants at both incisor area. He used 3.5 bright tissue level implant. The implants are well positioned as we planned. This is post-operative CVCT images. The fixtures are well placed and surrounded with intact bone. Honestly, this second live surgery case also was also taken 2 weeks ago. This is the clinical photo at 4 days after surgery. You can see the incomplete wound healing condition. I guess it would be better as time goes. Okay, let's talk about the Q&A session. Why do you use tissue level implant at today's live surgery? There are 2 types of implant in bright implant system, tissue level implant and bone level implant. As you know, we used to the bone level implant of bright system. However, tissue level implant also has many advantages. Especially, tissue level implant can endure more occlusal force than bone level implant. So we can place the tissue level implant 2.5 or 3.0 and 3.5 diameter tissue level implant at anterior area. When we choose the tissue level bright implant system, we can overcome the severely observed alveolar ridge without bone grafting. So we can achieve the minimalism implant surgery. So when we encounter the severely observed alveolar ridge, I recommend to use the tissue level bright implant system. Using the tissue level implant can reduce the bone grafting, so we can achieve the minimalism implant surgery. Okay. This is our live surgery for today's Dentium, and the next live surgery will be on February 1st with Dr. Chung. And thank you for joining us, and I wish to see you all again next time. Thank you.